Oligomenorrhea is defined as menstrual cycles that are unusually long, typically exceeding 35 days between the first day of one period and the first day of the next. In practical terms, a woman might experience a period in January, then not bleed again until March, effectively having only 2 cycles in a 3-month span. This pattern contrasts with the normal 21 to 35-day range and can be the first clue that the hypothalamic pituitary ovarian axis is out of sync. Irregular, infrequent periods are more than a nuisance. They signal underlying endocrine disruption that can diminish bone mineral density, raise cardiovascular risk, and impair fertility. For example, prolonged estrogen deficiency associated with oligomenorrhea accelerates bone loss, while the same hormonal milieu can increase LDL cholesterol and blood pressure. Early recognition therefore prevents long-term sequelae and guides targeted therapy. The hypothalamus secretes GnRH in a pulsatile fashion, which drives the pituitary to release LH and FSH. These gonadotropins regulate ovarian steroid production and follicular growth. When stress, excessive exercise, or chronic illness dampens GnRH pulse frequency, LH and FSH output falls, leading to insufficient estrogen stimulation of the endometrium and consequently elongated or missed cycles. Clinically, a patient may report a sudden change in cycle length after a period of weight loss or high emotional stress. PCOS is characterized by hyperandrogenism, chronic anovulation, and polycystic ovarian morphology. The excess androgens arise from theca cell hyperactivity, often amplified by insulin resistance, which suppresses normal follicular maturation and leads to numerous immature follicles visible on ultrasound. Patients typically present with oligomenorrhea, acne, hirsutism, and obesity, and they have a 2 to 3-fold increased risk of developing type 2 diabetes. Both an underactive thyroid hypothyroidism and an overactive thyroid hyperthyroidism can alter menstrual frequency. Hypothyroidism often prolongs cycles to 45 to 60 days due to reduced metabolic rate and elevated prolactin, whereas hyperthyroidism may cause irregular bleeding or shorten cycles through increased sex hormone-binding globulin. A woman presenting with fatigue, weight gain, and a 50-day cycle should be screened for TSH and free T4 to rule out thyroid disease. Elevated prolactin interferes with GnRH secretion, leading to low LH and FSH, and thus anovulation. Common causes include prolactin-secreting pituitary adenomas, certain antipsychotic medications, and hypothyroidism. Patients may notice galactorrhea, breast tenderness, and menstrual intervals exceeding 45 days. A serum prolactin level greater than 25 nanograms per milliliter usually prompts MRI imaging of the pituitary. Premature ovarian insufficiency, POI, refers to loss of functional ovarian follicles before age 40, leading to low estrogen and high FSH levels. Etiologies include autoimmune oophorytis, genetic abnormalities, for example Turner syndrome, and iatrogenic causes such as chemotherapy. Clinically, women experience irregular or absent periods, vasomotor symptoms, and accelerated bone loss. Laboratory workup shows elevated FSH greater than 40 international units per liter on 2 separate occasions. Congenital adrenal hyperplasia, CAH, leads to excess adrenal androgen production due to enzyme deficiencies, most commonly 21-hydroxylase. The surplus androgens suppress follicular development, causing anovulation and oligomenorrhea. A teenage girl with early pubic hair, acne, and a 40-day cycle should be evaluated for elevated 17-hydroxyprogesterone to confirm CAH. Certain drugs alter neurotransmitter pathways or hormone metabolism, leading to menstrual disturbances. Typical antipsychotics block dopamine receptors, which can raise prolactin levels. Likewise, some hormonal contraceptives containing progestin alone may suppress the hypothalamic pituitary axis enough to produce sparse bleeding. Switching to a different formulation or adjusting the dose often restores a more regular pattern. Intense physical training, chronic psychological stress, or a body mass index below 18.5 signal the body to conserve energy, suppressing GnRH release. Female athletes, ballet dancers, or women undergoing severe caloric restriction frequently present with cycles longer than 45 days and may also experience bone density loss. Addressing energy balance and stress management typically normalizes menstrual function within 3 to 6 months. Chronic diseases such as poorly controlled diabetes mellitus or end-stage renal disease disrupt hormone metabolism and alter the hypothalamic pituitary feedback loop. Hyperglycemia can exacerbate insulin resistance, which in turn increases ovarian androgen production. Uremia can impair gonadotropin secretion. Women with long-standing diabetes often report cycles extending beyond 40 days and may benefit from tighter glycemic control alongside endocrine evaluation. GnRH is secreted in pulses of roughly 60 to 90 minutes. This rhythmicity dictates the relative amounts of LH and FSH released from the pituitary. Reduced pulse frequency favors FSH suppression and preferential LH release, fostering anovulation and luteal phase defects. Stress, weight loss, or high prolactin can blunt the pulse generator, explaining why many women with oligomenorrhea have a blunted LH surge. A hallmark of PCOS is an elevated LH to FSH ratio, often greater than 2:1. Excess LH drives theca cell hyperplasia and androgen synthesis, while relatively low FSH fails to support dominant follicle maturation. The resulting androgen excess impairs follicular arrest, leading to the characteristic string of Pearl's ovarian morphology and irregular menstrual bleeding. When ovulation does not occur, the corpus luteum source of progesterone does not form, leaving the endometrium underprepared for the proliferative secretory transition. The thin, estrogen-dependent lining may shed irregularly or not at all, producing prolonged intervals between bleeds. Women with chronic anovulation often report spotting or amenorrhea rather than a classic heavy period. Insulin resistance causes compensatory hyperinsulinemia, which potentiates ovarian theca cell androgen production and reduces hepatic synthesis of sex hormone-binding globulin. The net effect is higher free testosterone, further disrupting folliculogenesis and extending menstrual cycles. For instance, a woman with a HOMA-IR score greater than 3.0 often displays both oligomenorrhea and clinical hirsutism. Population-based studies estimate that 5 to 15% of women of child-bearing age experience oligomenorrhea at some point, making it a relatively common gynecologic presentation. The prevalence rises in cohorts with high obesity rates or intensive sports participation, reflecting the influence of lifestyle and metabolic factors on menstrual regularity. Oligomenorrhea most frequently emerges during adolescence as the hypothalamic pituitary axis matures, and again in the 20 to 30-year age range when conditions such as PCOS or thyroid disease become clinically apparent. A smaller secondary peak can appear after age 35, often linked to declining ovarian reserve or emerging endocrine pathology. Epidemiologic data reveal higher rates of PCOS-related oligomenorrhea among Mediterranean, Middle Eastern, and South Asian women, possibly due to genetic predisposition and dietary patterns. Conversely, Northern European cohorts report lower prevalence, underscoring the interaction between genotype, environment, and lifestyle. Obesity, particularly central adiposity, exacerbates insulin resistance and androgen excess, creating a feedback loop that intensifies cycle irregularity. In PCOS populations, up to 70% are overweight or obese, and weight loss of just 5 to 10% of body weight can markedly improve menstrual frequency. The primary clinical hallmark is a cycle length that exceeds the normal 21 to 35-day window. Women may describe skipping one or more periods, noticing a gap of 45 to 60 days between bleeds. This symptom alone warrants a structured menstrual diary to differentiate true oligomenorrhea from occasional missed periods due to acute stress. Even when bleeding occurs, the duration 3 to 7 days and volume light to heavy may fluctuate markedly between cycles, reflecting inconsistent endometrial growth. Some patients observe a brief spotting phase, followed by a heavier flow, while others have scant bleeding only after long intervals. Because ovulation is irregular or absent, conception probability drops dramatically. Epidemiologic studies show a 2 to 3-fold increase in time to pregnancy among women with oligomenorrhea. Clinical workup often includes ovulation confirmation, for example, luteal phase progesterone, before proceeding to fertility-enhancing therapies. Concurrent endocrine signs help narrow the underlying cause. Hirsutism and acne point toward hyperandrogenism, PCOS, adrenal hyperplasia. Rapid weight gain or loss may signal thyroid disease. Milky nipple discharge suggests hyperprolactinemia. Fatigue, heat intolerance, or cold intolerance align with thyroid dysfunction. A comprehensive review of systems is essential. Patients should be instructed to record the first day of each menstrual bleed for at least 3 consecutive cycles, noting flow intensity, accompanying symptoms, and any intercurrent illnesses. This diary provides objective data to calculate average cycle length, identify patterns, and distinguish primary from secondary oligomenorrhea. A focused exam includes measurement of height, weight, and calculation of BMI. Inspection for acne, seborrhea, frontal hair thinning, and excess terminal hair, Ferriman-Galwey score. These findings correlate with hormonal imbalances and guide subsequent laboratory testing. Baseline labs typically comprise FSH, LH, estradiol, prolactin, TSH, free T4, total and free testosterone, and DHEAS. An elevated LH over FSH ratio, high testosterone, or increased prolactin narrows the differential to PCOS, adrenal hyperplasia, or prolactinoma, respectively. Estradiol below 30 picograms per milliliter suggests hypoestrogenic states, such as POI. A metabolic panel includes fasting glucose, insulin, lipid profile, and HbA1c. The homeostatic model assessment of insulin resistance, HOMAIR, helps identify insulin resistance, a key contributor to PCOS-related oligomenorrhea. Dyslipidemia, elevated triglycerides, low HDL, further signals cardiovascular risk that should be addressed concurrently. Transvaginal ultrasound, or transabdominal in virginal patients, visualizes ovarian morphology, the presence of greater than or equal to 12 follicles 2 to 9 millimeters in diameter, or an ovarian volume greater than 10 milliliters, is diagnostic for polycystic ovaries per the Rotterdam criteria. Endometrial thickness should also be measured. A thin endometrium less than 5 millimeters may indicate hypoestrogenism. When serum prolactin is markedly elevated, greater than 200 nanograms per milliliter, or a pituitary mass is suspected clinically. A gadolinium-enhanced MRI of the sellar region is ordered to identify microadenomas, less than 10 millimeters, or larger lesions. Detection guides treatment with dopamine agonists versus neurosurgical refer. In cases of suspected intrauterine adhesions, Asherman's syndrome, or septate uterus, Hysterosalpingography or office hysteroscopy evaluates the cavity. Scar tissue can obstruct menstrual outflow, mimicking oligomenorrhea, and requires hysteroscopic adhesiolysis for restoration of normal bleeding. Primary oligomenorrhea appears within the first few years after menarche and often reflects delayed maturation of the hypothalamic pituitary axis, genetic variants, or congenital endocrine defects. These patients usually have no prior history of regular cycles. Secondary oligomenorrhea develops after a previously regular menstrual pattern, suggesting an acquired disturbance such as weight loss, thyroid disease, or new medication use. The temporal relationship to a triggering event is a key diagnostic clue. Functional oligomenorrhea is driven by reversible factors. Excessive exercise, caloric restriction, or chronic psychosocial stress that suppress GnRH pulsatility. Modifying these behaviors often restores normal cyclicity without pharmacologic intervention. When a specific organic or endocrine disorder is identified, the condition is termed pathologic oligomenorrhea and requires targeted medical therapy, in addition to lifestyle counseling. A balanced diet providing 30 to 35 kilocalories per kilogram body weight, adequate protein 1.2 grams per kilogram, and micronutrients calcium and vitamin D supports normal HPO axis function. Moderate aerobic activity 150 minutes per week and stress reduction techniques such as mindfulness or yoga have been shown in randomized trials to shorten cycle length by up to 10 days in women with functional oligomenorrhea. Combined oral contraceptives, COCS, supply steady estrogen and progestin, suppressing ovarian androgen production and providing a predictable withdrawal bleed each month. They also improve acne, hirsutism, and reduce endometrial hyperplasia risk. Choice of low-dose estrogen, 20 to 30 micrograms ethinyl estradiol, with a third-generation progestin, offers good cycle control with minimal weight gain. Cyclic progestin involves taking a progestin, for example, medroxyprogesterone acetate 10 milligrams, for 10 to 14 days each month, inducing a withdrawal bleed that mimics a natural luteal phase. This regimen is useful for women contraindicated for estrogen or who desire minimal hormonal exposure. Metformin improves peripheral insulin sensitivity, lowers circulating insulin, and consequently reduces ovarian androgen output. In PCOS patients, a dose of 1,500 to 2,000 milligrams daily can shorten cycle length, increase ovulation rates to 30 to 40% per cycle, and aid weight loss of 2 to 5 kilograms over 6 months. Hypothyroid patients receive levothyroxine titrated to a target TSH of 0.5 to 2.5 ml international units per liter, which typically restores menstrual regularity within 8 to 12 weeks. Hyperthyroidism is managed with thionamides, methimazole, or definitive therapy, radioiodine, after which cycles often normalize within 3 months. Cabergoline 0.25 to 0.5 milligrams weekly, or bromocriptine 1.25 to 2.5 milligrams daily, decrease prolactin secretion via D2 receptor stimulation, restoring GnRH pulsatility. Serum prolactin typically normalizes within 4 to 6 weeks, and ovulation resumes in 70 to 80% of patients. Clomiphene citrate, 50 to 150 milligrams daily on days 3 to 7, antagonizes estrogen feedback, boosting FSH release. Letrozole, 2.5 to 5 milligrams, blocks aromatase, lowering estrogen and similarly increasing gonadotropins. Letrozole has a higher ovulation rate, approximately 70%, and lower multiple pregnancy risk, making it first line for PCOS-related oligomenorrhea desiring pregnancy. Addressing dyslipidemia, hypertension, and impaired glucose tolerance concurrently with menstrual therapy reduces long-term cardiovascular risk. Lifestyle counseling plus statins for LDL greater than 130 milligrams per deciliter, or metformin for fasting glucose greater than 100 milligrams per deciliter are common adjuncts. Patients should be re-evaluated every 3 to 6 months, review menstrual diary, repeat hormonal panels if symptoms persist, assess BMI, and adjust pharmacotherapy. For example, switch COC brand if breakthrough bleeding occurs. Annual bone density testing is advised for women with greater than 2 years of hypoestrogenism. Screening tools that ask about rapid weight loss, high-intensity training, and menstrual history can flag adolescents and athletes at risk for functional oligomenorrhea. Early counseling reduces the likelihood of progression to bone loss or infertility. Teaching patients to meet at least 1,200 kilocalories per day. Include 0.8 to 1 gram protein per kilogram. Maintain a BMI of 18.5 to 24.9. Help sustain adequate leptin levels, which are essential for normal GnRH secretion. Calcium 1,200 milligrams and vitamin D 800 international units are emphasized to protect bone health. Annual health checks for women with irregular cycles should incorporate TSH, prolactin, and fasting glucose. Early detection of subclinical hypothyroidism T, SH 4.5 to 10 m/IU per liter, or mildly elevated prolactin 30 to 80 ng per milliliter enables prompt treatment before oligomenorrhea becomes entrenched. With appropriate lifestyle, hormonal, or metabolic therapy, 80 to 90% of women achieve a cycle length of 21 to 35 days within 3 to 6 months. Regular cycles are associated with improved quality of life scores and reduced anxiety about fertility. If the underlying etiology is controlled, spontaneous ovulation can resume, and natural conception rates approach those of the general population. In refractory cases, assisted reproductive technologies IUI, IVF yield pregnancy rates of 20 to 35% per cycle, comparable to other infertility etiologies. Prolonged hypoestrogenism leads to a 2 to 3-fold increased risk of osteopenia or osteoporosis, and a 1.5-fold rise in coronary artery disease. Studies show that women with greater than 2 years of oligomenorrhea have lower lumbar spine bone density, T-score approximately -1.5, and higher LDL cholesterol, underscoring the need for early intervention. Genome-wide association studies have identified variants in DENND1A, THADA, and GATA4 that increase susceptibility to PCOS-related oligomenorrhea. Functional analyses suggest these genes modulate androgen biosynthesis and follicle development, opening avenues for personalized therapeutics based on genotype. Emerging data on GLP-1 receptor agonists, for example liraglutide, and SGLT2 inhibitors show promise in reducing insulin resistance, promoting modest weight loss, and normalizing menstrual cycles in obese PCOS patients. Small randomized trials report a 40% increase in ovulatory cycles after 6 months of therapy compared with metformin alone. Anti-Müllerian hormone, AMH, correlates with the count of antral follicles. Elevated AMH greater than 5 nanograms per milliliter is a reliable indicator of PCOS, while very low AMH less than 1 nanogram per milliliter signals diminished ovarian reserve. Serial AMH measurements can predict response to ovulation induction and guide individualized dosing of gonadotropins. Phase 2 trials of depot GnRH antagonists, for example elagolix depot, demonstrate the ability to reset GnRH pulse frequency, leading to restored ovulatory cycles after a brief treatment course. Adverse effects are minimal, and the approach may become an alternative to chronic hormonal contraception for women desiring future fertility. Mobile applications that log cycle dates, bleeding intensity, and lifestyle variables, combined with wearable-derived heart rate variability, can identify subtle deviations from baseline